Hi guys, so now we're beginning off with the integrated renal system. Here we are going to be talking a lot about physiology because renal physio is the foundation of understanding everything in medicine from the renal system. And in this system, we shall be talking about acid-base imbalance as well, which is a short question, that you get. A core medicine topic which gets you a question in all exams is what we're going to be talking about in this system. So then let's begin off with the renal physiology. So before we start off some formula for you, so here you can be asked these formulae as numericals or the concept behind them can be asked. So first we're talking about renal clearance. So renal clearance basically means that what is the rate of the plasma that is being cleared. Okay, so the unit of this is going to be ml per minute. The unit itself tells you a lot that how much volume of plasma is being cleared every minute by the kidney. Okay, so the formula here is UV by P. So you remember UV by P, meaning what is the urine concentration of X, what is the plasma concentration of X, and V means what is the flow rate of the urine. So basically UX and PX are concentration, which is going to be mg per ml or whatever is the unit. They're going to cancel each other out. So whatever is the unit of flow volume of urine is going to be the unit of clearance. And this is how you can actually remember formulae. And you can actually crack a numerical if you're not very confident of the formula in the exam hall. Just think how the units fit together, and sometimes that might help recall the formulae. Okay, so this is, let's say I'm considering the clearance of pH, a compound called pH. So the concentration of pH in the urine upon the flow rate of urine, which is V, upon the plasma concentration of pH is what is defined as the clearance. So now for a clearance to be equal to glomerular filtration rate, a substance has to be freely filtered from the Bowman's capsule. Yeah, it is coming via the glomerulus. It has to be freely filtered into the Bowman's capsule for the GFR to be equivalent to the overall net clearance. Now, if somebody's clearance is more than GFR, it means that there's a component of tubular secretion which is happening. If the urinary clearance is less than GFR, it means that it is getting reabsorbed. Eventually, whatever was filtered was not getting excreted. So that means something has reabsorbed it. So that's how the clearance helps you. So just to document whatever I have said, if the clearance is equivalent to GFR, that means that a substance is freely filtered and then nothing else happens to it. It is neither reabsorbed nor secreted. If the clearance is more than GFR, meaning eventual excretion is more than what was filtered, it means that there is tubular secretion. And if the clearance is less than GFR, it means that something got reabsorbed. So based on this, I want you to look here first, that what is the clearance? So clearance of pH is the maximum. In fact, this is a compound which is filtered by the GFR and then there is tubular secretion. So basically whatever comes in, everything is excreted. So can I say that this is equivalent to the amount of total plasma flowing through the kidney or the blood flowing through the kidney, because everything is excreted. Yeah. So for measuring the renal plasma flow, what we can do is we can estimate the clearance of pH. Okay. Then we have creatinine. Creatinine is also filtered and then there is certain amount of tubular secretion. Okay. So some amount of secretion happens, and inulin is a substance which is freely filtered. No reabsorption, no secretion. So can I say that for estimating GFR, I can measure the inulin here? Yeah, so we measure the clearance of inulin for GFR. Now creatinine, you must have heard that. So on a day-to-day basis, creatinine is one of the most commonly done RFT tests, right? So creatinine actually gives us estimated GFR. It is not the best for GFR because some amount gets secreted. I hope you understand that. But we can estimate GFR because that secretion is not much. Alright, so this is how creatinine value gives us estimated GFR. Okay, so this is about the three compounds. After that, we have urea clearance. Now clearance of urea is lesser because a lot of it is reabsorbed mainly by the PCT, proximal convoluted tubule. Sodium, at least 99% of the sodium is reabsorbed and 100% glucose is reabsorbed in patients with normal glucose. Very, very important. 100% glucose is reabsorbed in you and I who do not have any hyperglycemia. But if somebody has hyperglycemia, let's understand what happens and why glycosuria happens. So the glucose reabsorption is happening via SGLT2. I hope you remember from diabetes where I've taught you SGLT2 inhibitors. Yeah. So SGLT2 is what reabsorbs the glucose from the kidney. Sodium dependent glucose transport is what is happening. So in patients who have normal glucose, not an issue, what is going to happen is everything gets reabsorbed, everything is along the green line. Now, if theoretically the glucose exceeds 375 mg per minute, what happens is this is the TM. This is where all of the transporters are saturated. No more glucose can be reabsorbed. Everything is working at its full capacity. So this is when you will start to have excretion. Yeah. So this is where technically you should have excretion somewhere around here. But what we are observing in practice is that while around 200 mg per dl plasma glucose, renal excretion of glucose starts, which is glycosuria begins. So why is this happening? If the threshold theoretically Tm was 375, why is the threshold known as 200? So this difference between the threshold and Tm, the two T's, is known as the splay phenomenon. Alright, so the reason behind the splay phenomenon is basically hypothesized to be the fact that not all transporters have the same efficacy. Like a lot of you are watching this BTR, not everybody is gonna get a rank 1, but one of you who is utilizing it to the best of the ability, or a lot of you are utilizing it to the best of your ability, you're gonna get good ranks, So basically it also depends on your ability to perceive, not a very good feeling example, but that's how it is. Not every transporter has the same efficacy. That is the principle behind splay. Okay, so these are the terms you want to be confident with. This can be asked to you in a graphical manner, that at beyond what threshold do you start to have excretion? So the answer becomes 200. The theoretical splay transport maximum is 375. Alright, so this is about the glucose reabsorption. So going back to our formulae, we have done clearance. We have seen how to measure GFR using clearance of inulin. We have seen how to measure RPF using clearance of pH. You also want to remember RPF is not the same as renal blood flow. So if I want to measure renal blood flow, what I have to do is take the RPF upon 1 minus hematocrit. So this is the formula for renal blood flow. What about filtration fraction? Filtration fraction is GFR upon RPF. Alright, so this is glomerular filtration rate upon the renal plasma flow. So these are the formulae that you need to be aware of. So now we talk about countercurrent mechanism. So here you want to understand there are two things and only one word you want to remember. Who regulates this? What is the function? So we have one countercurrent multiplier and we have one countercurrent exchanger. Basically this principle is how do we make the urine as hypertonic as possible? How do I reabsorb the maximum amount of water, and who helps me do that? So countercurrent multiplier, remember, is the loop of Henle. Multiplier M is the main guy. Alright, so this is the main structure which creates that concentrating segment in the medulla which allows us to reabsorb water. So that is loop of Henle. And countercurrent exchanger is who helps in the maintenance. So there are two mains here. Main is multiplier, but maintenance is via exchanger, and this is via the vasa rectae. Alright, so just remember this table about these two because it's slightly confusing. You're going to mix these two terms up. Okay, so now let's talk about the filtration pressure. So if this is the glomerulus and this is the vessel, this is the afferent arteriole which is coming in, and you have the efferent arteriole which is going after the glomerulus, what is going to happen is you're going to have filtration, glomerular filtration occurring through this point. What is the net filtration pressure? So it is going to depend on one, the hydrostatic pressure of the glomerulus plus the oncotic pressure of the Bowman space. The oncotic pressure of the glomerular space is going to oppose this, right? So you can see the direction. So you can see this is going to favor the filtration, PGC, whereas the oncotic pressure of glomeruli is gonna not favor the filtration. Alright, and exact opposite happens with the Bowman space, wherein Bowman space hydrostatic pressure is against the filtration, whereas oncotic pressure of Bowman space is in favor of filtration. So simply put, you have P of GC and pi of BC and the other way around. Alright, so what you can see is that the pressure of the glomeruli and the oncotic pressure of Bowman space minus PBS and pi GC. I hope you got this. This is the net filtration pressure. It is roughly 10 to 15 mm in this direction. So the net pressure is towards the filtration of substances. We need to know how it will change when these parameters change. Okay, so this is what we want to understand. Before that, what you want to understand is with all of these changes, how GFR, RPF and filtration fraction change. So two concepts I'll give you. Glomerular filtration rate obviously will depend on the blood which is coming into it. So whenever I am doing afferent arterial vasoconstriction, the GFR reduces because the blood incoming reduces. Whereas if I do efferent arterial constriction, overall the pressure increases, yeah, PGC increase. So now the GFR increases. Got this? But renal plasma flow, overall the amount of plasma flow will decrease no matter which artery constricts. So either of them constricting, my overall renal plasma flow reduces, and that is the mistake you would make in the exam. So this is very important, that RPF reduces no matter who constricts. So now talking about filtration fraction, this is how the question will be framed, because you will have to apply both of these things, isn't it? So in afferent arterial constriction, both the numerator and denominator, so FF is GFR plus. So filtration fraction, as we discussed, is nothing but glomerular filtration rate upon RPF. So when both are reducing, this undergoes no change. But here what is happening? The numerator is increasing and denominator is decreasing. So filtration fraction increases in efferent arterial constriction. So this is what makes for a very good question. Then if I increase the plasma protein concentration, can you understand how now this pressure is increasing? The oncotic pressure of the glomerulus is increasing. So what will happen to GFR? GFR reduces. There is no change in RPF. Filtration fraction drops. Whereas if low plasma protein concentration is going to happen, the opposing factor goes down. So GFR increases and filtration fraction increases. On the other hand, if we do ureter vasoconstriction, what about ureter vasoconstriction? So whenever ureteric vasoconstriction happens, what happens is this opposing pressure, which is the PBS, again that increase, the Bowman's capsules pressure increases. So again the GFR drops and overall the filtration fraction reduces. Okay, so this is how ureteric constriction can also lead to renal failure by reducing the GFR, is what you want to understand here. Okay, so this is about the net filtration pressure, and the most complicated questions can be solved if you've understood this table in INI-CT as well. Okay, here two more concepts that you want to understand here. One is, what do NSAIDs do? For you to understand what NSAIDs do, you first know what prostaglandins do. So prostaglandins are going to preferentially dilate the afferent arteriole. So whenever afferent arteriole dilates, both of these things increase. Yeah, NSAIDs are going to block this. So NSAIDs basically decrease the GFR, is what you want to understand. What do ACE inhibitors do? For that you want to know what angiotensin does. So angiotensin preferentially does vasoconstriction of efferent. So it increases the GFR. So ACE inhibitors again decrease the GFR. Okay, so this is what these two drugs do. They reduce the GFR, and that is why both of them can actually cause pre-renal AKI. Okay, that is one applied concept that you can learn here as well. So now let's talk about the different parts of the nephron. So we've done the glomerulus and the Bowman's capsule. Now let's see what happens in the different segments. Very, very important. So first nephron segment is PCT. PCT is the site where almost all of the reabsorption of sodium, glucose and urea happens. Okay, so this is the main segment where we are talking about sodium reabsorption, glucose reabsorption, urea reabsorption as well as bicarbonate reabsorption. Okay, so this is very, very important. How is glucose reabsorption? Like we said, SGLT2. So sodium and glucose, sodium dependent glucose co-transport, this is unidirectional and it requires energy in the form of an ATP pump. All right, so this is what we have also studied in biochemistry when I was teaching you the transport mechanisms. Okay, so this is about how glucose gets transported. Along with that, you can also see sodium is getting reabsorbed. So this is how the direction is. This is the urinary lumen, whereas this is the blood where everything gets reabsorbed. So you can see how sodium is getting reabsorbed with this and with the bicarbonate channel. So how bicarbonate reabsorption happens? For that we have these sodium and H plus exchange channels. Sodium and H plus exchangers are present here. what they do is this H plus is brought into the lumen. That is going to combine with the bicarb, which forms bicarbonate. When carbonic anhydrase acts on it, it converts to CO2 water, goes inside and becomes bicarb again, and this H plus is thrown out, whereas bicarb is reabsorbed. So in short, without complicating, you want to understand that this enzyme is very important. It is crucial for bicarb reabsorption. So anytime we block carbonic anhydrase, which acetazolamide does, what is the problem going to be? The problem is going to be with the fact that bicarb reabsorption does not happen, and that leads to what? When body bicarb reduces, base reduces, it leads to metabolic acidosis. So this is what you want to remember here. 2 points. One is acetazolamide. That's how you're going to remember this drug now. Acetazolamide causes metabolic acidosis. Second, if there is a defect with this channel, not a drug that we're giving, but a defect, again it would lead to renal tubular acidosis because of renal tubule. Yeah, and what kind would be this? This would be proximal RTA, which is type 2 RTA. This would be proximal RTA, which is type 2 RTA is what you want to understand. Alright, so this is about the PCT. I hope you've understood. Sodium maximum reabsorption, entire glucose, urea and bicarb is happening here. Following this, we have the thin descending loop of Henle. It is only permeable to water. What it does is it allows for water reabsorption. So can I say that this is the concentrating segment of the tubule or the nephron? Yeah, so this is where only water reabsorption happens, and once the urine crosses thin descending loop of Henle, a lot of water has been reabsorbed. It is pretty concentrated. Going on to the thick ascending loop of Henle, this is where you have the famous NaK2Cl channel. So what you want to remember, sodium, potassium and chloride reabsorption is happening here. So you can see this, and this is the channel where loop diuretics act. This is the channel where the defect is going to lead to Bartter syndrome. So this point onwards, you're going to remember Bartter loop diuretics are synonymous. They are not going to allow sodium, potassium and chloride reabsorption to occur here. And along with this, basically what happens when all of these things are getting reabsorbed, we have sodium, potassium and chloride getting reabsorbed. Because of this positive potential, you have magnesium and calcium which also get reabsorbed via paracellular transport. Very important. There is no channel. It is via paracellular transport that these get reabsorbed here. Okay, so this is thick ascending loop of Henle. Remember, here it's the electrolyte. So this is a diluting segment. This is impermeable to water. This is the diluting segment. Then we go on to DCT. Again, very important. Here you have the NaCl channel. When NaCl channel is not working, sodium and chloride reabsorption will not happen. This is the site of action of thiazide, or if I have to tell you a defect, this would be Gitelman. Yeah, so this is how Bartter, Gitelman, furosemide, thiazide go together. Okay, so this is NaCl which are not allowing sodium and chloride reabsorption to happen. In addition, now you have magnesium and calcium channels which are causing the reabsorption. This is the site where PTH acts. Very, very important. So what you know about PTH? So we know that PTH is increasing the calcium reabsorption in the urine, and the site of action is DCT. Okay, so this is about DCT. Going on to the main thing, very, very important. Collecting tubule has principal cells, alpha intercalated cells, beta intercalated cells. In principal cells, what you want to remember is we have aldosterone which is acting. Once you know aldosterone and its functions, everything here becomes very easy. So what aldosterone does? It causes sodium and water reabsorption, and it causes K plus and H plus secretion. Yeah, so that is what is going to happen here. That is what we are going to be seeing, that throughout these cells, what we are having is sodium reabsorption, water reabsorption, but potassium is getting excreted, and in the alpha intercalated cells, you have H plus which also gets secreted. Alright, so potassium and H plus secretion. back into the urine, whereas sodium and water reabsorption. The water reabsorption predominantly is via the ADH-induced aquaporin 2 channels. ADH attaches to V2 receptor, which causes aquaporin 2 to attach here, which mainly does the concentrating, which causes the H2O to be reabsorbed. Okay, so this, if you just remember the action that these two are acting on the final collecting tubule, everything is sorted here. Yeah, and the channels on which the aldosterone is acting is ENaC epithelial sodium channels. These channels could be blocked directly by amiloride or triamterene, which are known as potassium sparing diuretics. And you also want to remember, when you have an activation of this channel, this is known as the Liddle's syndrome. Okay, so this is all about the tubules, if you just have a basic idea. So just to tell you what you have to take away from this is not every concept that I have taught you. Remember, PCT, everything reabsorption is happening. Remember, proximal RTA is happening at this level. Second one, thick ascending loop of Henle is where loop diuretics and Barter come in. DCT is where thiazide and Gitelman come in, and also PTH causes reabsorption at this level. Everything else, the answer is going to be collecting tubule. So in the principal cell, you have water reabsorption by aquaporin 2 and ADH, which is happening. You have the ENaC channels, which absorb the sodium and secrete potassium. And in alpha intercalated cells, you have H+, which gets secreted. Now, when H+ does not get secreted, so now in distal RTA, what's going to happen? This H+ will not be excreted or secreted in the urine. So more H+ remains in the body. Yeah, so there is failure of acidification of urine which is happening here. So this is how distal RTA is going to function. So distal RTA or type 1 RTA is what you want to remember. So distal RTA or type 1 RTA is going to happen at this point. Okay, so this is all about the tubules that you want to know. Now let's talk about renal tubular acidosis. We've already talked about the basics. So now let's just bring it all together. So type 2 is when PCT, there's a defect of bicarbonate channel. Bicarbonate reabsorption doesn't happen. So effectively it is metabolic acidosis. Type 1 RTA is where H+ secretion doesn't happen. In the distal or basically the collecting tubule alpha intercalated cells, when this does not happen, this is basically again effectively more H+ in the body. So this is type 1 RTA. Overall, what is the most common type is type 4 RTA, wherein you have hypoaldosteronism. Alright, so aldosterone goes low, again H+ secretion suffers. Okay, what you want to remember is one poem here. So the poem goes 2, 1, 4, low, low, more is the sentence. Alright, so you pause the video and you recite it on your own. 2, 1, 4, low, low, more. So 4 and more are rhyming. Remember that, otherwise you forget it. Okay, so the type of RTA is type 2, type 1 and type 4. You just write what you were saying, 2, 1, 4, and then you make this table. The table starts off with potassium. So 2, 1, 4, low, low, more. And this is RTA over. Game is over now. So remember, type 1, potassium is low. Now, whoever is rank 1 in life, you know, whoever are the toppers, they're always very greedy. They want more of everything. So they want more of calcium, they want more of pH, they also want stones. So we're going to say, all right, you keep all of it. The other people, bichara, are all going to have everything low. All right, so that is how we completely do RTA. Alright, so 2, 1, 4, low, low, more, and then you give topper everything, everybody else loses. So this is RTA for exams. Now let's just understand it one more time. So type 2 RTA is the proximal tubule. Remember, type 2 RTA, you have Wilson's disease, which is one cause, and you have Fanconi's disease, which is a failure of reabsorption of everything in the proximal tubule, are all causes of type 2 RTA. Alright, so what happens here? The calcium is low, potassium is low, so the pH is low. So here the pH which I'm talking about is urinary pH. Alright, so the urinary pH is going to be low because bicarbonate reabsorption is not happening. In type 1 RTA, what is happening? Potassium is again low, but calcium is going to be high, and urinary pH is also high. Urinary pH is high because there is failure of H+ secretion. Yeah, I hope you understand that. And nephrolithiasis is associated here. With type 1, you want to remember type 1 for Sjogren's. Alright, so Sjogren's syndrome, autoimmune A1 is what you can remember, are all going to be causes of type 1 RTA. Type 4 is hyperaldosteronism, and remember, one of the common causes of this is obstructive uropathy. Alright, so obstructive uropathy is one of the causes. So this is RTA in a nutshell, a very difficult topic otherwise. We just remember one poem and we are sorted. Okay, so now next topic that we're going to discuss, because we've already done the different tubules and their functions, let's just do all of the disorders, and this is as easy as anyone can make. So this flowchart, if you understand the concept, everything gets sorted. So now let's talk about the different tubular disorders. So we have already seen thick ascending loop of Henle, NAK2Cl means the problem is with Bartter. So this is either the furosemide or the Bartter syndrome. DCT NaCl channels not working is the Gitelman syndrome. Okay, so now these two are definitely must know, but there are three others that we want to know, which are tubular disorders. So exact opposite of Gitelman, when NaCl channels of DCT are overactivated, gain of function mutation happens here. This is Gordon syndrome. It is on, alright, auto on. So this is Gordon. So how you remember is both the G's are for DCT NaCl channels. This is Gordon, means it is gain of function. Whereas in the collecting duct, the ENaC channels where the aldosterone was acting, if that doesn't work, this is known as pseudo-hypoaldosteronism. It does make sense, isn't it? That aldosterone, it's actually there, but because the channel is not working, it appears as if there's hypoaldosteronism. Whereas if this channel is autoactive, this syndrome is known as Liddle syndrome, like I already told you. So this is how, once you know what these defects are, the pathophysiology becomes very easy. So now let's understand Bartter-Gitelman. The manifestations are going to be the same except for the calcium. Because in both of these, sodium, water and potassium reabsorption is not happening, you're going to have hypotension, you're going to have potassium which is low, and remember potassium and H plus always go in the same direction. So whenever potassium is low, alkalosis, the name itself tells you potassium low, alkalosis. Alright, so this is going to be the common manifestation of both of these. Calcium is where you distinguish. So urine calcium, if we are talking about, loops lose calcium. I'm sure you remember this line, loops lose calcium. Who is like loop diuretics? It is Bartter. So remember, urine calcium increases here, or the other way, serum calcium reduces. Alright, so urine calcium is always preferred way of diagnosing. So urine calcium is low, thiazides basically preserve, reabsorb calcium, whereas in Bartter, calcium is going to be increased, alright, in the urine. So this is how you crack Bartter and Gitelman. So now when I know Bartter-Gitelman, isn't Gordon very easy? Because it is the exact opposite of Gitelman. So I just have to make this opposite. So this becomes acidosis, whereas the other two increase, and now from this point onwards nothing happens to the calcium. Okay, what about pseudo-hypoaldosteronism? The name itself tells you when aldosterone is not working, the channel is not working, the BP is going to be low. Potassium secretion, that is what aldosterone was supposed to do. So when aldosterone is not there to remove the potassium, so when the potassium is increased, H plus is also going to be increased, so there is going to be acidosis, right? So if you just remember the concept here, everything becomes very easy. What about Liddle's? Once you've cracked pseudo-hypoaldosteronism, Liddle is exact opposite. So there is gain of function, so more sodium reabsorption, and there is more H plus and K plus excretion. So this becomes alkalosis and hypokalemia. Alright, so this is about Liddle syndrome. In fact, in the endocrine system, we've done a flowchart, if you remember. If you have not seen that, you can see it next. It will make a lot of sense. We've done one flowchart with hyperaldosteronism, wherein you have the same manifestation as hyperaldosteronism in Liddle's, except for the fact that aldosterone levels are low. Okay, why low? Because ENaC is auto-activated. Aldosterone is just chilling out that somebody is anyways doing my job. Alright, so this is one place where renin aldosterone is low, but the manifestations are like hyperaldosteronism. Okay, so again, this becomes very easy. Just what you want to do, if this is the first time you are looking at this, you just want to go back to the non-annotated workbook, just try and fill this yourself, just try and apply your concepts and try to fill this. If you don't understand, look at the video one more time. Okay, so this is tubular disorders. Once you've done this, pharmacology of diuretics, very important otherwise, but now it becomes a cakewalk. So first of all, remember there are 5 groups of diuretics that we have. The first one is mannitol. Mannitol mechanism you can see here at number 1. It is nothing but osmotic diuresis. It's an osmotically active agent, so it just promotes osmotic diuresis. What you want to remember as far as mannitol is concerned, that you can use it for cerebral edema, you can use it for angle closure glaucoma. However, it is contraindicated in pulmonary edema because that way it is going to increase the preload and further aggravate the cardiogenic pulmonary edema. Alright, so this is about mannitol. Second is acetazolamide. So we already know this is acidazolamide. It is acting at the proximal convoluted tubule. The side effect is going to be RTA, nothing but type 2 RTA. So acidazolamide. It can also promote NH3 toxicity because H plus excretion is impaired. So NH4 plus excretion is impaired. This is a sulfur drug. It can also cause hypokalemia and it can also cause stone formation. Then we have the loop diuretics. You already know where it acts. It acts at the ascending loop of Henle, isn't it? Just like Gitelman. And then you have thiazides. Let's just do them together. It acts at the DCT. So both of them we already know the functions. For loop diuretics per se, what are the specific side effects that you have? It is an ototoxic drug. Very, very important. Both of these agents are going to cause hypocalcemia. Just that loops lose calcium. Yeah, you want to remember loops lose calcium. So the urine calcium here is increased, whereas thiazides, you want to remember, they reduce the urine calcium and that's why it can be used in idiopathic hypercalciuria. Okay, so this is one thing. Then it can cause dehydration. Remember, these are sulfur drugs. So furosemide is a sulfur drug and contraindicated in sulfur allergy. It can cause alkalosis like we have seen with Bartter-Gitelman, interstitial nephritis and gout because it causes hyperuricemia as well. Same with thiazides. Remember the metabolic side effects. It causes hyperuricemia, hyperglycemia and urine calcium is reduced. It is the drug of choice. Very important, this table for thiazides. Thiazides are the first line drugs to be given in hypertension and heart failure, idiopathic hypercalciuria. They are also the drug of choice for nephrogenic DI. This also we have already seen in endocrine and they can also be used in osteoporosis. Okay, because they reduce the urine calcium. Fine. So this is about these. Finally, the last group of drugs at the collecting duct are all of your potassium sparing diuretics, isn't it? Because they cause these are your potassium sparing diuretics. So here what you want to remember, we have the seat group of drugs. Alright, so this is your seat group of drugs. So these are the seat group of drugs. So you want to remember, keep your seat, meaning potassium here is going to be high. So these are potassium sparing diuretics. Apart from that, for spironolactone per se, you want to remember it can cause gynecomastia and has anti-androgen effects, in which case you can use the other ones like eplerenone, amiloride and triamterene. Okay, and it also causes metabolic acidosis. So this is about all of the diuretics. Once you've understood what the tubules are doing, this is just very easy. So now just one more concept that we want to discuss about the renal physiology that we had left out is about juxtaglomerular apparatus. So it basically includes 3 cells. You want to know the function of each of these cells. Macula densa is one cell which is very, very important for the exams in the recent times. You know, every exam you're getting one question on this. It is a cell which is located between the DCT and the thick ascending loop of Henle. So that's the first question. Where are these cells located? Between the DCT and the thick ascending loop of Henle. What is their function? Again important, they help in the tubuloglomerular feedback. Not the other way around, tubuloglomerular feedback. The name itself tells you everything. What they're going to do is they're going to be the chemosensors of the tubules. They are going to sense how much sodium chloride is coming. So if high amount of sodium is coming, very high sodium is coming, it gives the feedback to glomerulus, bro, you gotta chill, you gotta constrict. Alright, so what's gonna happen? If sodium is very high, you're gonna have vasoconstriction of the afferent arteriole and overall then the sodium will reduce. Basically the GFR reduces, so obviously sodium reabsorption reduces. Okay, so this is what is the feedback. The mediator here for afferent arteriole constriction is what is the repeat question? It is adenosine. Now if the sodium coming is very low, it tells the glomerulus, bro, you got to do some more work. What happens is vasodilation of the afferent arteriole happens and the GFR further increases, and this is mediated via NO. nitric oxide. Alright, so this is about the tubuloglomerular feedback, which is mediated by macula densa, adenosine, NO. Potential questions. Then we have the juxtaglomerular cells. As you know, these are the main cells mediating the renin, angiotensin, aldosterone system. So they are known as the baroreceptors of the glomerulus. So these are modified smooth muscle cells in the afferent arteriole. So what they do is that they sense the GFR. If the GFR is low, what they are going to do is they are going to cause renin to be released. This renin is going to further activate the angiotensin 2, which further activates the aldosterone, which causes more sodium and water reabsorption, and that is how this is accounted for. Alright, so this is the renin, angiotensin, aldosterone system. The third cells are just the Lasik cells. Just want to remember that these are mesangial cells which have some sort of anti-inflammatory property. Okay, so this is about all of these three cells. Now going on to glomerulonephritis. So we've done the physiology, now medicine path integration in glomerulonephritis. So how we're going to do this here? I think the Achilles heel here is the location of deposits and the images of path, isn't it? So that's what we're going to crack. We're going to do it in 2 more slides, and that's it about glomerulonephritis from 2 big subjects. Okay, so first of all, look at the schematic. Let's just get the deposits out of the way and then we go to individual diseases. So here, first of all, you need to understand the anatomy. So the easiest is mesangium. You can have mesangial deposits. That's the easiest. So here you have this glomerulus. So in the glomerulus, what you see here as the glomerular barrier is the endothelial cells. These are endothelial cells. So in the schematic, what you're seeing here are the 2 epithelial layers. These are epithelial foot processes, whereas this is the epithelium here, and you also see the endothelial processes and the endothelial spaces. Now the deposits could be either subepithelial. What you are seeing in the schematic 1, they are subepithelial. In type 2, what you are seeing, that they are within the membrane, so that is known as intramembranous, and type 3 is when they are just below the endothelium or just above the endothelium, that is subendothelium, and 4 is the easiest, that it is mesangial. So same schematic, if you understood, the same picture you see on electron microscopy, which is one of the challenges for students. So what you have to start off, always start off with the foot processes. Yeah, so these are the foot processes or the podocytes that you are seeing here. This is the endothelial cell, and in between them is the basement membrane. So if you see the deposits somewhere here, they are subepithelial. If you see the deposits here, they are intramembranous, and if you see endothelial cell is displaced here and the deposit is somewhere here, that is subendothelial. Alright, so this is how we go about deposits. So where all do you see which deposits? So number 1 was subepithelial, right? Subepithelial deposits, remember, are seen in 2 extremes of ages. Subepithelial humps, if they describe. You want to remember children. Children love to ride camels. Camels have humps. So you remember the glomerulonephritis most common in children, which is PSGN, post-streptococcal glomerulonephritis. Okay, so that is subepithelial humps. Subepithelial spike and dome pattern, if you are seeing, this is a finding that you're going to see in elderly population. In elderly, the most common nephrotic syndrome is the membranous type. So remember, membranous nephropathy is not causing membranous deposits. Very important. Okay, so this is subepithelial. Second was intramembranous deposits. So membranous deposits you want to see are seen in MPGN, membranoproliferative glomerulonephritis type 2. This is also known as dense deposit disease. Okay, and finally we have the subendothelial deposits. Subendothelial deposits are going to be seen in MPGN type 1. It is also seen in lupus nephritis. Alright, so SLE we have already talked about. Remember the full house effect which I have taught you, that is subendothelial deposits. And finally number 4, that is mesangial proliferation. This is IgA or Berger's disease. Okay, this is the toughest part to remember this. So how we remember? Subepithelial extremes. Humps is camel, so PSGN, remaining is membranous. Intramembranous is MPGN type 2, MPGN 1, and lupus is subendothelial. Fine. Let's just do this right here, right now. What you see is the membrane looking like basket weave. Look at this weaving nature here, okay? So this is known as the basket weave appearance of the basement membrane, and this is seen in a disease which is a defect in type 4 collagen, which is Alport's syndrome. So before I go into Alport syndrome, let's just do all type 4 collagen disorders. So what you want to remember is, you write this way: alpha 3, alpha 4, alpha 5. There could be a defect in either of these chains. How to remember the order is Grand Theft Auto. Those of you who know, GTA is a game, right? It's a video game. I know only that much. So you remember GTA, which is alpha 3, alpha 4, alpha 5. Alpha 3 is your G for good pasture syndrome. In good pasture syndrome, what is going to happen is you're going to have anti-glomerular basement membrane antibodies, and this is what causes hematuria. This also tends to affect the pulmonary capillaries, so you also have hemopsis. So this is one of the examples of renopulmonary syndrome. Another differential for this would be microscopic polyangiitis. Another differential for this would be Wegener's granulomatosis. All right, so very, very important. So this is alpha 3. Alpha 4 is a familial disorder. So this is known as T for thin basement membrane disease, also known as benign familial hematuria. Benign familial hematuria. Okay, so this is alpha 4. Alpha 5 is Alport. This is what we wanted to talk about. So Alport is basket weave. What happens in Alport syndrome? You have a triad of 3 findings. So what 3 findings? Let's go inside this membrane and write. So the first is going to be the eye. This I've taught you in ophthal as well. This is anterior lenticonus. Remember, posterior lenticonus is Lowe syndrome. Lowe syndrome is oculocerebrorenal. So just the brain is missing. So anterior lenticonus, kidney, we have already seen that there is going to be basket weave, there's going to be hematuria which is present, and you have SNHL. So here you have ear, eye, and kidney which is affected. Okay, so this is about Alport and all of the collagen disorders. So this was your GTA. Okay, so this very, very high slide, this you have to revise. Now, it's going to be very easy. So, I'm going to tell you buzzwords, you're going to tell me diagnosis. So, in the kidneys, in the glomerulonephritis, we have nephritic syndrome, we have nephrotic syndrome. Nephritic syndrome is where the name itself tells you there is itis, there is inflammation. So, you are going to have the symptoms as hematuria predominant, which presents as cola colored urine. So, remember, anytime you have hematuria of glomerular origin, the color is going to be cola colored, and the hallmark is the fact that there are dysmorphic RBCs. Dysmorphic RBCs, and you have casts, RBC casts which are present. Alright, this is how you distinguish glomerular and non-glomerular hematuria. Okay, you will have oliguria, you will have hypertension. So now the description. So if I tell you there is a child, the most common nephritic syndrome in a child, you will have the history that the hematuria started 10 to 21 days, 2 to 3 weeks after either a throat infection or a skin infection. So the most common one, PSGN, post-streptococcal glomerulonephritis. What you're going to be seeing on light microscopy is a lot of proliferation. You're going to be seeing a lot of cells, a lot of inflammations in the glomerulus. What deposits? You already know this. This is subepithelial, P for PSGN, P for epithelial. And what do children sit on? Camels, so subepithelial humps. And on immune fluorescence, you are going to see C3 and IgG getting deposited in a granular fashion. So this is PSGN. Alright. On the other hand, if I tell you it's an adult, the most common cause of nephritic syndrome in adults, and I tell you that this is synpharyngitic. Understand the difference. Very, very important. This is post-pharyngitic. This is synpharyngitic, occurring simultaneously as the pharyngitis. This is hematuria 3 days after the pharyngitis, and you're going to have recurrent gross hematuria. So this is IgA nephritis, also known as Berger's disease. Alright, so this is Berger's. Contrast this with BUER, Berger's disease, which was vasculitis, smoker's may, thromboangiitis obliterans. Yes, you remember that? Corkscrew collateral, neutrophilic microabscesses. We've studied this in rheumat. Okay, so this is IgA nephritis or Berger's disease. What you're going to be seeing here is mesangial proliferation. So you're going to have mesangial proliferation, and on immunofluorescence, you're going to have IgA, which is getting deposited in the mesangium. Okay. Going on to the third type, here what you have is rapidly progressive course. Alright, so this could be a complication of any of the nephritic or nephrotic syndromes. Here the course is rapidly progressive, and what is the hallmark here is crescent. So this is also known as crescenteric glomerulonephritis. Okay, the question is, what are these crescents formed of? You can see these crescents, right? So what are these crescents formed of? So the easy part would be fibrin and WBC. The third and fourth option is where we usually get stuck. So there you would see visceral epithelium and you would see parietal epithelium. So what you want to remember is that it is parietal epithelium which contributes to the crescents. Okay, so here it could be because of immune deposition such as complication of PSGN, or it could be posse-immune wherein you have Wegener's granulomatosis complicating it, or it could be because of good pastures like we have already seen. Okay, so this is a complication and the diseases are basically included in other spectrums. This is just based on the course that you're going to diagnose it. Okay, so this is PSGN, IgA and RPGN. Nephrotic syndrome, the hallmark is proteinuria. You have complete destruction of the glomerular basement membrane and the filtration barrier, which results in huge amounts of protein getting lost, and the definition is more than 3 gram per day getting lost, which results in hypoalbuminemia resulting in edema, and because so much lipid is getting lost, that is known as frothy urine. And one more thing because of lipiduria is this Maltese cross appearance. 2 more places we've done this. In micro, we've studied Maltese cross in babesiosis, and in biochemistry, I've taught you this in Fabry's disease. Okay, so there are 3 Maltese cross that you want to remember, 2 in urine, 1 in blood. Okay, so now let's guess the diseases. The most common nephrotic syndrome in children, this is minimal change disease or MCD. Alright, so minimal change disease, as the name says, the light microscopy is going to be completely normal, whereas it's the electron microscopy which is diagnostic, wherein you see that the foot processes are all effaced. So this has been asked so many times. This results in the effacement of the foot processes. Yeah. Apart from that, the typical history would be the child who would have had prior history of URTR immunization, and the associations in nephrotic syndrome are very important. So this is associated with NSAIDs and most important, Hodgkin's lymphoma. The most common type in adults is focal segmental glomerulosclerosis. So focal segmental glomerulosclerosis means few of the glomeruli are involved and they are involved in parts. Alright, so this is the meaning of focal, few involved, segmental, half glomerulus getting involved. Alright, so here you have various histories. So what you want to remember is heroes. Alright, so heroes, heroine and HIV. HIV further has a subtype wherein you are going to be seeing these very pinky material. That's how a radiologist would describe this image. This is known as the collapsing variant. Alright, so this collapsing variant frequently associated with HIV and also with COVID-19. Alright, so with COVID-19 also COCO, you can remember this. Apart from that, other risk factors could be say reflux nephropathy, obesity, sickle cell anemia. The congenital variant of FSGS is nephrin. So this is a congenital nephropathy in which you have Finnish type. So frequently this is basically steroid resistant MCD or FSGS is the presentation. Okay, so this is nephrin, which is the Finnish type of nephropathy is what you want to remember. Then the one which is most common in elderly. So what did we say? This we already know, elderly, membranous, and it was with PSGN, so P for subepithelial, but now it is spike and dome pattern. Yeah, so this is your subepithelial spike and dome. Can you see how this is the basement membrane, this is where you have endothelial, so the deposits are below the epithelial cells. Okay, here the risk factors are frequently malignancy, so this is associated with adenocarcinoma of lung, colon or melanoma, and one very important type is phospholipase A receptor 2 mutation associated with membranous. Last type is MPGN. MPGN is frequently seen in adults. You have two types. MPGN type 1, you want to remember, is tram track appearance. There's going to be thickening and splitting of the basement membrane, whereas type 2 is going to be the dense deposit disease. This is where you have membranous deposition. Can you see the thickening of the membrane on electron microscopy? So this is where you have intramembranous deposits. This is where you have only C3, because here they say that there is C3 nephritic factor, C3 neph, which is positive. Associations would be few infections like HBV, HCV and malaria. Okay, so this in a nutshell, if you can just revise these two slides, your glomerulonephritis from not just two, three subjects, medicine, peds and path, more or less gets sorted. Okay, so this is about this. So now we are going to core medicine of the renal system. Alright, so first we want to learn how to distinguish AKI versus CKD. So these are certain factors that could be given to you as clinical scenario. So this is what we want to learn. So first of all, CMD means corticomedullary differentiation. Alright, so corticomedullary differentiation is what you have to learn between AKI and CKD. So in acute kidney injury, CMD is maintained. This is what we see radiologically. So radiologically, if you have ever seen a kidney, the cortex appears hypoechoic, darker, whereas the pyramids appear hyperechoic. Okay, so this differentiation is maintained in AKI, whereas it is lost in CKD, because overall the kidneys become very, very white, very, very echogenic, and the size contracts. All right, so the kidney is contracted with CMD, which is lost, whereas the size is also maintained in a acute kidney injury. In AKI, the urine osmolarity could be anything. It is variable depending on the type of AKI, like we will study, will depend on whether it is pre-renal or renal. But in CKD, it is going to be constant. It is going to be fixed, which is known as isosthenuria. Alright, so isosthenuria is when the specific gravity is fixed at 1.010. Now, what about anemia? So now remember, in anemia, because you have erythropoietin deficiency in CKD, that is why you're going to have anemia, whereas anemia would never occur in a AKI setting. You would never have metabolic bone disease in an AKI setting. It usually occurs in CKD. This is what we know as secondary hyperparathyroidism or renal osteodystrophy. The casts which are present in AKI will depend on pre-renal or renal. So in the renal type or in acute tubular necrosis, you're going to have granular casts. Alright, so these are known as granular or tubular casts, whereas in a CKD, you are going to have waxy or broad casts. Very, very important. Alright, so I'm going to show you all of these images as well of the cast, because this can come as an image-based question as well, and this is your clue. Believe me, this is the buzzword that you want to look out for. Alright. So now let's just do the AKI types and then I'm going to show you those casts. Okay, so pre-renal versus ATN. So now we are talking about acute kidney injury, whether it is because of the GFR dropping that the kidney is failing, or it's the tubules fault, which is acute tubular necrosis. So remember, pre-renal certain causes would be shock, hypovolemic shock, and something that we have studied in GI system, which is hepatorenal syndrome. So these are causes of pre-renal shock. Whereas in acute tubular necrosis, you have sin. You want to remember, it's a sin to cause AIN. Yeah. So you could have sepsis, you could have ischemia, or you could have nephrotoxins, right? So nephrotoxins could be drugs, it could be contrast agents. So this is about sin. It could be myoglobinuria. So all of these are nephrotoxins. So remember, sin is acute tubular necrosis. So now how to understand this table is very simple. You just want to remember, in pre-renal, the tubules are all fine. They are doing their job of reabsorption very well. It's just that they are not getting any blood, and that's why they are failing. In ATN, they are not working. So they're going to let go of everything that normally they would reabsorb. Yeah. So let's start this from below. This is the most important thing that is usually given in the questions. Fractional excretion of sodium. So what happens in pre-renal? The FeNA, the fractional excretion of sodium, is normal. Normally, less than 1% of sodium is excreted, same in pre-renal. But when the tubules are not working, more than 1% sodium gets excreted. Putting a number to it, urine sodium here is more than 20, whereas it is less than 20 in pre-renal. Same concept. Urine osmolarity. Again, because in pre-renal, everything is working fine. Body is trying to reabsorb more and more water in order to save from the pre-renal shock. What you want to do is, the osmolarity is very high. Whereas because in ATN, all of the water is also getting lost, no reabsorption is happening, the osmolarity drops and it is less than 350. There are no real casts that you see in pre-renal, whereas the cast in ATN, like I have already told you, are either muddy brown or granular or tubular casts. Muddy brown, granular or tubular casts. Now, what about the urea creatinine ratio? Because in pre-renal, the urea reabsorption is happening just fine, the urea is higher. So, the ratio is more than 20:1, whereas here the urea drops, and that is why this ratio is less than 10:1. Creatinine is going to be high in both of them, yeah. But because we are talking about urea, just the same concept. Urea reabsorption is happening, so that's going to be high in pre-renal. Okay, so this is about this very, very important table. Believe me, if you just remember FeNA less than 1 in pre-renal, no, your job would be done. Alright, what about the biomarkers of AKI? This is AIMS INI-CT potential question. So, cystatin C, KIM1, NGAL, TIMP2 and IGF-BP7. You would want a mnemonic, but just go through this list and if an odd one out comes, you will be able to recognize. Okay, so this is about AKI. So now let's talk about all of the casts. Let's try and recognize them because this could be an image-based question. So the first one that you are seeing are nothing but hyaline casts. Remember, hyaline casts are normal. They can be seen under normal circumstances also. Maybe under stress like fever or high amount of exercise, you can have hyaline casts coming into the urine. These are known as Tom Horsfall protein. Alright, so they consist of this Tom Horsfall protein. Remember, they could be seen under fever, high stress or exertion. Okay, so this is hyaline casts. On the other hand, when you start seeing cells, just see the color. If it appears like cola or red color, these are your RBC casts, whereas these are your WBC casts. WBC cast would be seen in pyelonephritis, whereas RBC cast would be seen in glomerulonephritis. Like we've already seen, in glomerulonephritis, you'll also have dysmorphic RBCs. Okay. Then what you're seeing here is known as a granular cast, and you are also seeing a muddy brown cast here. So granular or a tubular cast, basically all of these are going to be seen in acute tubular necrosis, whereas if you see this broad or this waxy cast, this is what you see in CKD, chronic kidney disease. Alright, so this is about the urine cast. Now let's talk about a few renal path images that you get. So this appearance is showing you a very waxy appearance of kidney. This is a feature of amyloidosis. We have talked about amyloidosis in path, general path, right? So you can just revise that from there. You also want to remember that kidneys are the most common organ to be affected in amyloidosis. What you are seeing here is the typical flea-bitten kidney, very, very frequently tested, the causes of flea-bitten kidney. So one is rapidly progressive glomerulonephritis that we've already studied. It could also be seen in PSGN or malignant hypertension. Okay. On the other hand, this appearance here is what is known as a leather grain appearance of the kidneys, and this is associated with this. This is a frequently asked question. This is hyaline arteriosclerosis, which is noted in diabetes mellitus. Alright, one condition is diabetes mellitus. This used to be a favorite Viva question. I can still remember this. Okay, so this is leather grain and flea-bitten. Then cystic diseases. So the first two images are autosomal dominant PCKD, whereas this is ARPCKD. The trick is look at the outer surface. In autosomal dominant, you're going to have these large cysts. So the outer contour is irregular, whereas in ARPCKD, the outer contour is smooth. Alright, it is going to be very smooth. You have tiny cysts at the corticomedullary junction. You're going to have microcysts here. Okay, so this is how you want to distinguish these two. Remember the associations of ADP-CKD? You can have cysts in different organs like the liver, like the spleen, like the pancreas. You can have diverticulosis and you can also have berry aneurysms, okay? In addition to mitral valve prolapse. All of these are associations of ADP-CKD. Fine. So, this is about renal path. Now we go on to acid-base imbalance. Okay, so this is very, very important and very easy. Once you understand this, it's going to be very easy. So no mnemonics I want you to remember, no Rome, nothing. Just learn what I am teaching you. Alright, so just do the basics and you will never get a question on this wrong. So first you need to know what is the normal consideration. So remember 1 value. pH is 7.4 is normal, CO2 should be 40 and bicarb should be 24. Now, CO2 is our acid. It's the acid of the body. So, can I say anytime CO2 increases, there's going to be acidosis and I call that respiratory acidosis because CO2 is by the lungs. If CO2 is low, I call it alkalosis. If bicarb, which is a base, is high, it is metabolic alkalosis, whereas if the base is low, it is metabolic acidosis. Got that? So, now let's try and document this. So, let's fill this table. So, first of all, pH is the easiest. In acidosis, it is low. In alkalosis, it is high. Very baby stuff. What is the primary change? So, metabolic acidosis, the moment I hear metabolic, I have to write something must change with bicarb. Respiratory, something must change with CO2. Opposite would be the compensation. Yeah, so here compensating would be CO2, whereas here compensating would be bicarb. So far, so good. Now, metabolic acidosis, what happens to bicarb? The base must reduce, then only we'll have acidosis. In alkalosis, base must increase. In respiratory acidosis, acid must increase and acid must decrease. Very easy. What about the compensation? So, metabolic acidosis is happening. So, CO2 as an acid, what will he tell himself? That my body is under acidosis, I should sacrifice myself. So, CO2 decreases. In metabolic alkalosis, because body is in alkalosis, body needs acid, so acid increases. Respiratory acidosis, body has acidosis, so the base should increase, whereas respiratory alkalosis, body has alkalosis, so base should decrease. As simple as that. So, if you just understand acid base, this is nothing, alright. So, there is no need to remember any mnemonic here, alright. So, before I go into this, let's just solve this question and give you the confidence that you need. So, on lab investigations, pH is 7.3. The moment half of my answer is clear that if normal pH is 7.4, this is acidosis. So, two options I anyways rule out. Now, what do I have to see? PCO2 is 35. So, acid is low. If acid is low, can it be respiratory? No, means this is metabolic acidosis. So, the answer is already sorted. So, this is what you want to learn. One more question you want to attempt. pH is 7.12. So, automatically I know when I'm dealing with a case of acidosis, let me just rule out two options. Bicarb is 28, meaning base is high. So, it can't be metabolic acidosis, it is respiratory acidosis. So, my answer is clear. But I also want to learn about compensation. So, here the answer is pretty clear, but I also want to learn about compensation. Remember, at your level, compensation question can only come with one thing. I can teach you all compensation, but ultimately, you will not remember that. Ultimately, you only want to remember one Winter's formula, which is for metabolic acidosis. So, what is the Winter's formula? Very, very important. So, now let's talk about compensation. So, the most important which I feel, at your level you need to know is metabolic acidosis. For metabolic acidosis compensation, we use something known as the Winter's formula. What is Winter's formula? So, here what we do is the CO2 should be 1.5 into bicarb plus 8 plus minus 2. So, this is what is the value that you need to keep in mind for CO2. So, basically 1.5 into bicarb plus 8 is the value. Plus minus 2 is where the CO2 should be if there is compensation. If it is not falling in this value, you say it is partially compensated, otherwise you say it is completely compensated. For metabolic alkalosis, every 1 milliequivalent increase in bicarb should increase the CO2 by 0.7. Then for respiratory acidosis alkalosis, there are two things, whether it is acute or chronic, alright, whether it is acute or chronic. So first of all, for 10 mm increase in CO2, 10 mm increase or 10 mm decrease, the values of bicarb in acute chronic, remember the word 14. Basically not word, number, remember the number 14, so 1 4, then you just add 1 to each, so 2 and 5. So in acute respiratory acidosis, for 10 mm increase in CO2, bicarb should increase by 1 milliequivalent. For chronic, 4, acute is 2 and chronic is 5, this would be reduction. So this is how I had remembered legit when I was preparing also. This is the table that I had made. So what you want to do is, one, memorize Winter's formula. Just write it down 2 times. 1.5 into bicarb plus 8 plus minus 2. That's all you will be tested. But if you want to be very hyper and you want to remember everything, then you remember this. 1 and 0.7. 10 and 10, 14, which is 1 4, and 2 5, which is 1 1 increase. Alright, so this is how you remember compensation as well. Now let's understand this graph. This is a repeat AIMS question. Okay, so again very logical. So what you are seeing here is blood pH arranged on the x-axis, plasma bicarb on the y-axis. So we have to recognize all of these acid-base disorders in black boxes, which are these limbs of this crab-like graph. Okay, so when the pH is low and bicarb is also low, meaning base is low, so what should be the answer? This is metabolic acidosis. On the other hand, when you see that the base is high and the pH is also high, so can I say this is metabolic alkalosis? So now I am left with respiratory in all of them. Yeah, it has to be respiratory for all of them. Now I can also say which is acidosis, which is alkalosis. That's also very easy, that these two which are corresponding on the sides of low pH must be acidosis, these two must be alkalosis. But then what is acute, what is chronic is the trapper here, isn't it? So here what you want to remember is that the one which is closer to the midline, that is 7.4. In chronic cases, when you are studying and you are not clearing, you are gonna get used to it. It becomes like normal for you. So just like that, acid base, chronic conditions, it's gonna come near the normal. Yeah, so it's gonna be closer to the midline, whereas here this is acute, all right. So this is how we are gonna be arranging this graph. Okay, so this is also sorted. 2 MCQs done. Let's look at the last one. A patient who is a known case of CKD with vomiting, so multiple stuff is happening. ABG pH is 7.4. PCO2 is 40, bicarb is 25. Everything is normal. So it could be C or it could be any of the others. Whenever in the exam you are stuck in a situation like this, when they give you values of sodium and chloride, they are asking you to calculate an ion gap directly. Don't jump to normal thinking, wow, examiners are so kind, they give me a normal ABG. They'll never do that. Okay, so calculate an ion gap. How do you calculate an ion gap? So the formula is going to be add the anions, sodium and potassium, subtract the cations. Anything else is given, please don't add. Don't be over smart and say this is also an ion, I should add. No, just add sodium. Even if potassium is don't given, ignore. Don't again hypothesize that potassium must be 2 or 3 and let me add. No. So sodium plus potassium minus bicarb plus chloride. So this is what you are doing. So sodium plus potassium is not given, so I just take 145 minus chloride and bicarb. So this is 125, so this is 20. The normal anion gap is 12 plus minus 4, so 8 to 16 is the normal anion gap. This is high. So the moment I see that there is high anion gap, it has to be metabolic acidosis. Now the fact that it is high anion gap, metabolic acidosis cannot explain 7.4. So there has to be a component of alkalosis. Both are balancing each other out. So the answer is D. Alright, so this is how the moment you get high anion gap, it's metabolic acidosis and then it's compensated. Also gets explained, a patient with CKD because of uremia is going to have hagma, and because he has vomiting, he's also losing the acid, so metabolic alkalosis. So this exactly fits with his clinical scenario. Okay. Similarly, you also, I hope, understand when respiratory acidosis would occur. When you have CO2 which is high, means you have hypoventilation, whereas any condition which causes hyperventilation would have alkalosis. Very, very important is metabolic acidosis. So now let's understand all causes of HAGMA, which is high anion gap metabolic acidosis. So there would be certain clues to the clinical scenario, and then accordingly you answer the questions. So if they say that there is some sort of drug ingestion ka history, it could be isoniazide, it could be salicylate. So very, very important. Salicylate toxicity. So this causes a dual metabolic disorder. One is obviously HAGMA because salicylate itself is acidic, but early on what it actually does is it causes hyperventilation. So early it is going to cause respiratory alkalosis followed by HAGMA. Alright, so very, very important question for salicylate. When they tell you there is a shock with hypoperfusion, lactate is increased, it is lactic acidosis. As simple as that, high anion gap metabolic acidosis. Renal failure leading to uremia, as I said, HAGMA. Very important, hyperglycemia, diabetic ketoacidosis. And when they mention osmolar gap, extremely important, two causes. One could be methanol toxicity. This is frequently sold as desi daru is what we say. So this is responsible for the huge tragedy. Again, a repeat question. Another cause could be antifreeze or ethylene glycol. Alright, so ethylene glycol toxicity, which is a frequent antifreeze agent, will also have a high osmolar gap. Okay, so here what could also be given is calcium oxalate crystals. They also precipitate in the urine and they can form stones. This is an antifreeze agent, whereas in methanol you will have formic acid, which is the result, which can also cause vision loss. Alright, it can be toxic to the retina. So this is about the osmolar gap. In all of these causes, remember you have Kussmaul's breathing. Again, very, very logical. Because the body is in metabolic acidosis, we are doing deep breath, deep and frequent breaths, and the reason basically is to wash out CO2, wash out acid. Okay, so this is about HAGMA. You can also have normal anion gap metabolic acidosis known as hyperchloremic acidosis. The main cause is RTA. Very important, and the other cause is diarrhea. So for this, if they tell you urine anion gap positive, it is urine, so RTA. If urine anion gap is normal, it is diarrhea. Two other causes could be carbonic anhydrase inhibitor or urethral diversion. Not very, very important. Okay, so this is how we approach metabolic acidosis. So that's it as far as the renal and acid-base balance system goes. I've tried to compile everything which is important in the most conceptual manner possible for me. So I hope this is clear. Thank you so much. I'll see you with the next one.